Hi, this is Dr. Paul Cozy, and I have a case report I'd like to show for a patient with external resorption, and we're going to do a socket shield for this patient. Here's an x-ray showing the resorption. You can see where the tooth is actually being resorbed on the inside, canine tooth number 11. Here we're excising the area of resorption. And now I'm going to remove some of the outside enamel on the crown without disturbing the gingiva. Here we remove that, and you can actually see the internal resorption where it's taken place. We're cutting through the contact here. Like most external resorptions, there was no pain or symptoms with this situation for this patient. Here we're removing more enamel, and eventually we're going to remove the crown in just a moment here. Just checking the periodontal depth of any pockets. Really, it was normal all the way around the tooth. Possibly here on the distal it was 3 to 4 millimeters. Here we're cutting right through the crown, just above gingival level. You'll see the crown loosen up here in a minute. There it is. And now we're going to remove this crown, and you'll see the soft tissue that has been resorbing the tooth from the inside and the palatal side of the tooth. There's the soft tissue, and then this was excised and placed in a biopsy jar to be looked at later histologically. Really pretty firmly attached, as you can see. In-cutting periodontal instrument here to help excise this. And in a few seconds here we're going to go to a 12B blade. Final excision of the tissue that has been resorbing the tooth. And there that is. That was placed in the biopsy jar. And now the tooth is going to be prepared for the socket shield. This is a 557 surgical length burr in a 45-degree contra-angle handpiece, penetrating right up the canal of the root, center of the root, and then going mesial distal to section the palatal portion of the root. The tooth is saved on the entire area and also extending into the buccal contact area right under the papilla, as you'll see. Just measuring the depth. Looked like about 12 millimeters depth. Again, more work with the 557 burr. You can see what we've done so far. There's still portions of the root on the palatal side which we are now trying to elevate. Using some gentle tapping with this straight elevator. That is actually a sharpened straight elevator, very sharp, like an osteotome, and that palatal portion of the root can be removed with that. There's a small piece of the root removed. little more tapping because we hadn't really totally sectioned the tooth buccal facial. Now we're using 2.0 pilot drill, going right up the canal. Here we have a 15 endo file, just checking where that canal is. And here I'm using a Lindemann burr to slightly move my path for the pilot drill to the palatal side. This tooth was rather vertical as far as its orthodontic torque from having a 4x extraction orthodontic treatment. And here we're about 14 millimeters deep, just measuring that. This looks like the 2.0 pilot drill again, irrigating with saline, constantly irrigating, suctioning, and looking all the way to the tip of the root with magnification and a headlight. Notice two hands guiding the pilot drill, and that looks like about 200 RPMs. There's a PA of the pilot drill going right up the center of the tooth, and you can see mesial distal portions of the tooth remain. We're taking the depth to 15 millimeters. 15 millimeters at about the facial bone level. That was a 3.2 drill, and now this is a 3.7 drill. Again, notice the two hand on the handpiece to guide that, saving the bone as it comes out. Irrigation. Now the last drill is 4.1 drill, and our implant's going to be a 4.6 by 15. There again is the final drill, which was 4.1 drill for a 4.6 by 15 implant. And now we're just going to thin out the remaining root that will be facial to the implant and wrapping around into the papilla areas. Thin that out so that there's space, facial, and wherever the root is, space for bone to fill in between the implant and the remaining root. This is a traditional high-speed handpiece, and it's a coarse diamond burr that we usually use for crown crafts in the handpiece, and tap water for irrigation. Again, trying to avoid nicking any of the marginal gingiva on the facial and the papilla areas. Now here's the temporary prosthesis, which is an Emax Maryland bridge, pressed ceramic with palatal wings for bonded retention. Just trying it in at this stage. This looks like a Lindemann burr, and here is a 557, again, just thinning out the remaining root. Here I'm actually scoring the mesial and distal areas to get some bleeding into the socket area. And here we're just thinning again the remaining root. This is 45-degree handpiece. Gives a nice angle for reaching this area. Probing the sulcus, and it looks like it's about 1 millimeter. More thinning of the root, not touching the gingiva. Here I'm retracting the facial gingiva so as not to nick it as I do the final touch-up of the remaining root. This tool is a coarse diamond. It looks like it's more of a flame shape, just to get a better angle on this remaining root. Here's some PRGF placed to the apex, and here's the implant going in with a straight hand driver. First, get the implant in PRGF. This is a BioHorizon implant, taper plus, 4.6 by 15. You can see the implant does not touch that remaining root at all. I don't believe that's the final depth. I think we put it in another couple millimeters. I wanted to get at the facial bone level with the facial margin of the implant. And we're going to test the torque of the implant. Started at 25, and the implant did not move, did not rotate until 60 Newton centimeters on the torque wrench. There's a cover screw going onto the implant, 3 millimeter by 3 millimeter. Now we're going to try the prosthesis in, and you can see there's some space there. I want to make sure that the ponic did not touch the implant, so we actually relieve the tissue area of that. See the implant in place. Now we're placing some of the saved bone that has been mixed with some minerals and some PRGF liquid, and just filling all the gaps with that material. And then we put a little PRGF over this surface after the grafting was done. PRGF is then placed over the surface of the graft. And then a rubber dam is placed over that to protect the area while we etch the surface for the prosthesis, which again is an Emax Maryland bridge. Rinsing the etchant and drying. Resin cement is applied to the wing areas of the Maryland bridge, and the excess is cleaned up with composite instrument and Explorer, and then light cured. Bridge is held in place, and from the lingual, as you can see. Final cleanup for this floor, and then like cure. He has some air. Rubber dam is now removed by snipping the interproximals, and here's some PRF being tucked under the pontic from both sides. There was a slight gap under the pontic, which you can see there filled by the PRF. Well, thank you for watching, and now here's a review of the case from start to finish. You can see the resorption actually through the outside of the tooth. There's a good shot of the inside. Tooth again. Probing around the sulci. Minimal depth of the sulcus. There's the Emax bridge. See the wings on the bridge, and those are acid etched beforehand. Here's a nice shot of the final prep of the socket shield. See, we lost a little bone on the lingual, I think, from removing the root. There's the implant in place. Again, you can see the gaps around the implant. There's a bridge of Trian. There's the area after grafting. GF on the surface. Bonded to place with PRF at the margin. Final cone beam view, cross section, and the cross section just on either side of the implant. Here's the implant. You can see it's partially in the sinus, just into the sinus floor. With the frontal view, you can see the interproximal bone. That's all root on the facial there. And here we are 9 days post-op. Excellent healing. Patient had minimal discomfort, although she had a headache for 2 days. You can see we actually don't touch canine to canine. Essentially we do because of the bonding. There's the frontal view. And thank you for watching this case report, and we'll have follow-ups in the future. Thank you very much.